Hi, I'm Carolyn Sufrin. I'm faculty at Johns Hopkins, where I'm the Associate Fellowship Director in Family Planning. And today I'm going to talk about how I teach providing reproductive health care in a jail setting. Now, this may seem like an unusual place to learn about reproductive health care and not something that a lot of people have thought about, but there are actually a tremendous amount of benefits for patients and for learners to providing reproductive health care in jail and to recognizing that the inequalities and the systems level constraints that you see in jail actually pertain not only to this very marginalized population, but to all people seeking reproductive health care in the United States. And so I created a rotation for OBGYN residents to rotate at a jail, providing clinical care and also learning about the context. So what I'm going to talk about is how I teach in that setting, and many of these principles can be applied to rotations at other jails and prisons as well. So before even starting on the rotation, I communicate with the residents with some information, written information, and key articles that describe information about mass incarceration in the United States. And it, on the surface, has nothing to do with reproductive health care, right? But what the residents learn over the course of the rotation is that mass incarceration is actually a reproductive justice issue. And before entering into an institution of incarceration to provide care, we all need to be versed in the context of who is behind bars, why, and what that says about our country. So we go over a lot of that information on the first day. So on the first day of the rotation, we spend about an hour or so going over some critical context. So we talk about the fact that mass incarceration in the United States is a phenomenon over the last 40 years where we've seen this exponential rise in the number of people behind bars. So in the 1970s, on any given day, there were about 500,000 people in prisons and jails across the U.S., and now it's more like 2.1 million people on any given day. And that exponential rise, which is called varying things, but mass incarceration being one of them, is attributed to a complex intersection of forces that has actually very little to do with a rise in crime and a lot to do with draconian drug laws, the so-called war on drugs, with the criminalization of poverty, with lack of adequate mental health care resources, with various other economic forces that have increased poverty and unemployment, but also created incentives to build more prisons and jails for profit. And very importantly, as a result of institutionalized racism that is part of our country's fabric and also part of our medical system. And so understanding this context of mass incarceration is an essential part of how I teach the context of clinical care for providing reproductive health care in jail. So after going through some of that and some of the trends in why mass incarceration exists, we also talk about the paradox of healthcare for incarcerated people and the fact that since a 1976 Supreme Court case, Estelle versus Gamble, prisoners, incarcerated people have been the only people in our country with a constitutional right to health care. So they have a constitutional right to health care, which is unusual, right? Because they're incarcerated, they get most of their rights stripped from them, but they gain this right that no one else has guaranteed as a right. And then we talk about how, while that may be the case in the books and in theory, on the ground, the way that systems of healthcare are administered in institutions of incarceration is widely variable, and there is no mandatory standardization and no mandatory oversight, which means that the healthcare services that they're going to be providing at this jail differ very much from what might be provided at a jail, even in the next door county, because there's no mandatory requirements that a jail has to follow. So then we talk, after learning a little bit about that foundation of the existence of healthcare, we then talk a little bit more about women behind bars and the fact that the war on drugs has disproportionately affected women, and that women have been the fastest growing subpopulation of people behind bars than any other group in the last several decades. Even as the population of males keeps decreasing, the number of women continues to increase. We discuss how studies and various demographic reports from the Department of Justice have shown that the majority of women who are behind bars are of reproductive age. Most of them are mothers and the primary caregivers to young children. Most of them have been pregnant before. They have high rates of prior unintended pregnancies, a low prevalence of contraceptive use, and a variety of feelings about what they feel about pregnancy. And in reviewing this research and this demographic profile, what I also emphasize to the learners is these are studies, and what we're going to do is we're going to meet people for whom these experiences may resonate, and they also may have different life experiences. But understanding the context of mass incarceration, and that many women who are incarcerated, their lives are structured by what we sometimes in healthcare and public health think about as social and structural determinants of health. Those also overlap with some of the reasons why women are behind bars. So we go over a lot of this background information with a caveat that when they meet an individual patient, it's going to be different. We talk through a values clarification or a challenging patient workshop that was designed specifically for an incarcerated rotation, in that it presents scenarios of incarcerated patients who are coming to the clinic for reproductive health care. And so scenarios where a woman who is arrested for sex work or for a drug-related crime or for murder comes presenting for a certain reproductive health care service. Now, in real life, we don't actually ask patients what they're there for, but for the purposes of this values clarification exercise, we present these scenarios. And the idea is to get learners to question their assumptions that they might have about the people who are in custody and why they're there, and what their reproductive health care needs might be. A lot of people think, well, why would a woman in jail or prison need birth control? They shouldn't be having sex while they're incarcerated. But thinking through, that these people will get out, and maybe this is an opportunity for access. And we also talk through and question assumptions on the flip side. I've had some learners who think everyone should leave jail or prison with a birth control method. But that also has its limitations and has assumptions about the relative value of the reproduction of incarcerated people. So those cases help us talk about and introduce some of the concepts of reproductive justice and how people's reproduction is differentially valued, and that incarcerated women come from are a very marginalized group, and also are comprised disproportionately of people of color and people who whose lives are shaped by the structural racism of our society. So that comes through in the background and the values clarification workshop. Then after all this talking, we still haven't seen patients yet. This is all on the first day, because this is all essential information to think about when seeing patients in a jail setting. We then take a tour of the jail, and we go to one of the housing units so that the learners can see the physical environment that people are living in. They can see where the guards are positioned, how they're always watching people. They can see what the bathrooms, how those are set up, and the modified privacy. They can see on a population level in the jail, who the people are, and they can see very clearly that the people in jail are, for the most part, disproportionately women of color. So we take a tour first in the housing units. Then we go to the intake jail so they can see a little bit and learn about the protocols for what happens when someone first comes in, and how it's actually a nurse who's the first person they see when they come into jail, a nurse who triages their healthcare concerns. So we walk through that. We see the triage station. They get a sense of the energy of the intake jail. And then lastly we end up in the clinical setting, and we end up in the clinic exam room, which has a GYN table with stirrups, with a microscope, with other supplies. And then I use that to reinforce some principles we may have already discussed about who these women are and what some of their life experiences may be, especially the fact that the majority of incarcerated women have experienced prior physical, sexual, or emotional trauma and abuse. And this is relevant for the gynecologic exam because incarceration in and of itself can be re-traumatizing for people with these histories, and traumatizing even if you don't. But pelvic exams also can be re-traumatizing for people who have histories of sexual abuse. And that's very important to have this lens and some of the principles of trauma-informed care in this very delicate environment. So after we've gone through a lot of that background, there's lots of discussion, it's one-on-one teaching, then we start seeing patients. And patients are referred to us for a variety of reproductive health conditions, whether it's prenatal care for a pregnant woman, whether it's options counseling, postpartum care, whether it's screening for sexually transmitted infections, vaginal discharge, family planning discussions, chronic pelvic pain, abnormal uterine bleeding, fibroids, cervical cancer screening, breast cancer screening, any number of routine or problem visits for OBGYN care. But what the learners see over the course of the rotation is that for many of these patients, jail is the only place where they're able to access reproductive health care. And that helps them understand even better some of the shortcomings of the healthcare systems outside of jail, and to understand the connections between the two. Now, as we're providing care, after each patient, we have a mini debrief, and we discuss not only the very medical clinical aspects of her care, but some of the other contextual factors, like, well, what does it mean if we order a certain medication for this patient in jail? How is she going to get it? We talked about family planning and how she wants to be pregnant when she gets released. Or another patient who wanted birth control. What does it mean to talk about birth control or long-acting reversible contraceptive methods in this population? And with regards to the long-acting reversible contraception, we talk about remembering that this environment of incarceration is inherently coercive. It, by design, reduces people's autonomy in decision making. And while we may think that doesn't exist in a clinical environment and apply our principles of good care, the patients often come to clinic with the mindset of how they're being treated as incarcerated people, and that they have reduced autonomy. So we have to be very cautious to avoid undue pressure in choosing any method of contraception, and especially provider-controlled methods. And we do that through the counseling and discussion with the patients, and with certain protocols to make sure that they have adequate time for their decision, and to know that they have access to a full range of reversible methods. And then finally, in complement to all of these things, the background, the tour, the constant discussion and reflection, the patient-centered care, each week is also supplemented and guided by a selection of readings, mostly social science-related readings that have to do with mass incarceration, reproductive justice, understanding the intersection between the two, and other reproductive health-related topics, or articles about criminal justice system reform. And those readings we discuss each week, and the learners are challenged to apply that to individual patient scenarios as well. And by the end of the rotation, the learners are asked to write a reflection about their experience and a particular moment that, or patient interaction that struck them, or the entire experience, but to relate that to the care that they provide to non-incarcerated people. And through that reflection, the learners have shown a tremendous depth of knowledge and appreciation of the many complex factors of thinking about a system of punishment and a system of care, how those two intersect, but also how those intersections really guide a large part of our society, even outside the jail. And they take those lessons, they take that sensitivity, they take that knowledge with them when they're caring for patients presenting in any clinical setting for family planning and other reproductive health care. And that is how I teach caring for incarcerated patients.